All right, we're going to start with our first poster spotlight presentation, which is hybrid cervical and robotic assisted thoracoscopic resection of substernal goiters is superior to sternotomy, presented by Niranja Swaminathan from the University of Alabama at Birmingham.
Thank you so much for the opportunity to present. So today I'll be presenting our research on a less invasive alternative for managing substernal goiters. So while most goiters can be removed cervically, between 2% and 11% requires sternotomy, which is associated with significant morbidity, including a 20 to 30% rate of hypocalcemia and a 5 to 10% rate of nerve injury. Hence, the objective was to evaluate if a hybrid approach combining a cervical incision with robotic-assisted thoracoscopic surgery, also known as RATS, could offer better perioperative outcomes than traditional sternotomy. We conducted a retrospective cohort of over 7,300 thyroidectomies at our institution from 2012 to 2023. We defined substernal goiter as any thyroid tissue extending below the sternal notch on preoperative CT scans. Out of 255 substernal goiter cases identified, we compared 16 patients who underwent the hybrid cervical RATS approach against 13 patients who underwent traditional sternotomies. The outcomes that we assessed were operative time, blood loss, length of stay, intensive care unit admission, hypocalcemia rates, as well as recurrent laryngeal nerve injuries. So coming to our first results, when we looked at the demographics, there were no significant differences in age, sex, or BMI between the two groups. Most patients presented with symptoms like dysphagia and dyspnea. Coming to the operative outcomes, operative time was significantly shorter, a median of 3.2 hours with the hybrid approach versus 5 hours for sternotomy. Blood loss was also meaningfully lower, 180 ml versus 344 ml in the sternotomy group. Chest tube placement tells a particularly striking story. Only 25% of the hybrid patient required one, compared to 92% of the sternotomy patients. ICU admission rates trended lower as well, 13% versus 29%, but this did not reach any statistical significance, likely due to our sample size. Length of stay also followed the same pattern. Patients in the hybrid group went home in a median of 2 days, compared to 4 days for the sternotomy group. So to better understand what drove surgical decision-making, we also built a CT-based predictive model to quantitatively identify the anatomic features that favored sternotomy. 3 key thresholds emerged. Sternotomy was more likely when the goiter was within 7.2 centimeters of the sternal notch, within 3.5 centimeters of the aortic notch, and also larger than 6.8 centimeters in the AP dimension. Regarding the complication, while the differences didn't reach any statistical significance in this cohort, it is worth noting that the hybrid group had 0 cases of recurrent laryngeal nerve injury or perioperative mortality compared to 15.4% in the sternotomy group. In conclusion, the hybrid cervical RATS approach is a safe and effective alternative to sternotomy for substernal goiters. It is associated with significantly shorter operative time, less blood loss, and faster recovery for the patients. To better understand what drove surgical decision-making, additional qualitative consideration included deep mediastinal extension, large intrathoracic component, posterior mediastinal location, as well as proximity to major mediastinal vascular structures. Thank you so much, and I'd be happy to take any questions.
Thank you so much. We now open this to any questions from the audience.
Sarah Altman, UT Southwestern, no disclosures. Thank you for bringing your work on this. Can you talk a little bit about how you guys go back and forth between the chest and the neck? We've been doing this a little bit at our institution and found the operative times a little bit opposite, in part because of the changing of the robot, the change in the position. What is y'all's technique?
Thank you so much for the question. So how we used to do it is pre-operatively, we doing it in a multidisciplinary fashion, so we post the case as a combo case. So we don't post the case as just an endocrine case and require cold thoracic surgery at that time. So that actually helps us do a better preoperative planning approach. So typically what we do in the OR is, firstly, we start with the endocrine part of the case, and then we see if the goiter is deep down the chest, can we like deliver it through the cervical incision alone, or do we need like some thoracic surgery mobilization? And then since we post it as a combo case, once endocrine surgery is done, thoracic surgery typically comes in and do their part.
I guess my question is, what is their part?
Yeah, so for the robotic cases, we do it in a 4-port fashion. So we use 3 utility ports and 3 ports and 1 utility port. So we typically make the incision in the 7th intercostal space along the posterior axillary line as 1 port. And then the next port will be in the 4th intercostal space along the anterior axillary line for the camera port. And then 2 posterior ports at the back as well. So
And
that's the
then
position.
If you've done the neck part first, are you leaving the neck open, or are you cutting a cross specimen and allowing them to withdraw from the chest?
So we typically kind of just, I'm not sure if this is right, but we typically just put a gauze and see if once thoracic surgery is done, can we deliver the goiter through the neck incision? So we typically just leave it as it is while thoracic surgery do their part.
All right, thank you. That's all the time we have for questions for this particular poster. Thank you so much.
Next, we welcome Dr. Andrew Thornton from Columbia Medical Center, presenting prospective comparison of radiofrequency and microwave ablation for toxic thyroid nodules.
Morning. I'm Andrew Thornton. I'm one of the research residents at Columbia, and I'll be presenting our work on microwave versus RFA for toxic thyroid nodules. So our hypothesis was that microwave and RFA are both safe and effective treatments for toxic nodules. Our objective was to compare these 2 techniques. In terms of our methods, this was a prospective cohort study. Patients undergoing microwave or RFA for toxic nodules over 6 years at a single academic medical center. All ablative techniques were performed with transisthmic approach and moving shot technique. The primary outcome was biochemical resolution of hyperthyroidism. Secondary outcomes were nodule volume, volume reduction ratio, cosmetic and symptom scores, and complication rates post-procedure. In terms of our results, we had 64 total patients, 16 in the microwave arm and 48 in the RFA arm. We had a roughly equal proportion of toxic adenoma and toxic multinodular goiter. The baseline nodule volume was 4 cc's in each group, and both groups had suppressed TSH at baseline. In terms of our TSH, the microwave group is shown in red here, and the RFA group is in blue. You can see that each group normalizes within 1 month post-procedure, and at 12 months, both groups are still normal. There are faint gray lines that show the individual patient-level data. We had 2 cases of recurrence of hyperthyroidism in this group. They were both in the RFA arm. We had 3 cases of subclinical hypothyroidism. Those were also in the RFA arm. This is our volume reduction ratio. So at 3 and 6 months post-procedure, microwave had a greater volume reduction ratio than RFA. By 12 months, this was no longer statistically significant. In terms of our rate of ablation, microwave was about 2 times as fast as RFA. And for our complications, there were no hematomas, voice change, or cutaneous burns in either group. There was 1 nodule rupture in each group, 4 infections in the RFA arm, none in the microwave arm. And as I mentioned, there were the 3 cases of mild hypothyroidism in the RFA group. In terms of our conclusions, TSH normalized within 1 month and remained normal 1 year post-ablation for both RFA and microwave. Both techniques achieved over 84% volume reduction 1 year post-ablation. Microwave ablation is significantly faster than RFA. There were no major complications or voice changes. For future work, we should pursue larger multi-center randomized trials, and we need longer-term follow-up data to ensure the durability of this response. And with that, I'll take questions.
Abby Finger at University of Nebraska, no disclosures. Excellent paper, well presented, and congratulations to you and your group on such a large cohort of toxic nodules. I'm curious, at what point was microwave implemented, and how did you decide on microwave versus RFA? Follow-up question, what's the cost to initiate, and is there a cost difference for the patient? Thank you.
So we implemented microwave after RFA at our center. That's why we had fewer patients in that group. In terms of how we decided whether we would do microwave or RFA, we suspected that microwave was faster, so for larger nodules, we tended to choose microwave. You do get a little bit of a slower, more controlled burn with RFA, so if the nodule was closer to a critical structure, we would prefer RFA. In terms of the reimbursement, I'm not sure how they compare for the patients, to be honest. We'll have to look into that, though.
Thank you. I would encourage you to include that selection criteria in your paper because that may have introduced some bias.
Definitely. Thank you.
Thanks for your presentation. Can you comment on how you manage their thyroid medications post each of these techniques? Is it the same or does it vary?
So it's the same for each technique, and we routinely discontinue antithyroid medications immediately at the time of ablation.
So to answer Abby's questions, we started RFA in August of 2019. We started microwave in March of 2022. So that there's a big couple of years there. Before the CPT code got passed last January, most of these patients were self-pay. And our center just set the self-pay rate the same for both microwave and RFA. Post-CPT code, about 80% of these cases are getting reimbursed now, and so it's whatever the insurer decides to pay us for those. I think those were your questions, right?
Thank you.
Thank you. I think the next one's me, too.
Oh, yes, you are. All right, Dr. Thornton is going to stay up here because he's also presenting our next poster, which is diagnostic performance of Afirma grid signatures, excuse me, in predicting malignancy among oncocytic thyroid nodules.
So I'll be presenting our data on diagnostic performance of Afirma Grid GSC in oncocytic nodules. So a little bit of background. Afirma Grid summarizes whole transcriptome gene expression into 31 cancer-relevant gene sets to assist in the risk stratification of Afirma suspicious nodules. In terms of our objectives, we wanted to, one, evaluate Hürthle cell index, which is one of the grid signatures, for its ability to predict oncocytic change, and two, to assess individual signatures' capacity to rule out all malignancy. Our study population was Bethesda 3 and 4 Afirma suspicious nodules between 2018 and 2025. In terms of our statistical testing, AUC, logistic regression, and standard diagnostic performance metrics were used. For results, we had 360 Afirma suspicious B3-4 nodules. 245 of those underwent surgical resection. There were 39 cases of oncocytic cytology in the group that were resected. 22 of the 39 were malignant. And interestingly, only 6 of the 22 malignancies in this group were oncocytic carcinoma. The most common malignancy in this group was actually papillary thyroid cancer. So here we looked at Hürthle cell index's ability to predict oncocytic cytology. And we saw that it very strongly predicts oncocytic cytology. The AUC here was 0.88. Moving on to our diagnostic testing. This is the diagnostic performance for Hürthle cell index ability to rule out oncocytic carcinoma. And we found that at an optimized threshold, we had a 100% sensitivity and 45% specificity for oncocytic carcinoma. So our next question was if we were able to rule out all malignancies in this class. As I mentioned, there were other non-oncocytic carcinoma cancers. And here we found that even the top performing signatures had a residual risk of over 20% with a negative test. So our conclusions were that the most common malignant histology in nodules with oncocytic cytology is papillary thyroid carcinoma, not oncocytic carcinoma. Hürthle cell index is a quantitative predictor of oncocytic cytology. The Hürthle cell index demonstrates potential as a rule-out test for oncocytic carcinoma, but not all cancers. No grid signature was able to rule out all carcinomas. For future work, we recommend external validation at other institutions. And more complex predictive models than single threshold testing may be able to give us stronger results in terms of rule-out potential. I'll take questions.
would you counsel a patient who had testing that suggested an oncocytic presentation with their cytology and then with application of your grid signatures?
So I don't think that the results from the grid signatures would change how I would counsel a patient. Like I showed, we're able to rule out oncocytic carcinoma. I think that's interesting from a biological perspective and for Afirma. But there's still a significant enough chance of other cancers in this group that I think we still have to treat this as we currently do.
All right, thank you so much.
Thank you.
Next, we have Dr. Isabel Garcia from UT Southwestern presenting Balancing Benefit and Burden, Prolonged Iodine Retention After Lipiidol Lymphangiography Delays, RAI Therapy in Patients with Chyle Leak Following Lateral Neck Dissection.
Good morning. Thank you guys for the opportunity to present. I have nothing to disclose. So postoperative chyle leak after lateral neck dissection is a rare complication with possible treatments including Lipiidol for lymphangiography and thoracic duct embolization. Lipiidol is an iodine oil-based diagnostic and therapeutic agent that can be retained for months to years, causing persistently elevated iodine levels and thus may lead to a delay in RAI. Here we see an example of Lipiidol retention after thoracic duct embolization in a patient at 1 month and then 26 months after injection. Thus, we aim to characterize the impact of Lipiidol on RAI administration for differentiated thyroid cancer. We performed a retrospective review in Dallas, Texas from 2014 to 2025 of patients undergoing lateral neck dissections. We evaluated 121 patients and excluded any patient under 18 years old. We then compared patients with high volume chyle leak who required thoracic duct embolization versus all patients undergoing lateral neck dissections to measure their time to RAI. Our primary outcome was time to RAI, and our secondary outcomes were urine iodine clearance, recurrence, and response to treatment as classified by the ATA 2015 guidelines. We see no significant difference in our demographics, locations of the lateral neck dissection, or the ATA risk classification between our patients who received Lipiidol versus those who had the uncomplicated lateral neck dissection. Here we see a scatter plot that depicts the time to RAI for patients who received Lipiidol versus those with the uncomplicated lateral neck dissections, with the median time to RAI in those who received Lipiidol as 478 days compared to 72 days in the no Lipiidol group. Notably, the first dot on this graph does represent someone where the urinary iodine was not checked due to the lack of knowledge on the effects of Lipiidol versus the other two in which we did follow their urinary iodine clearance. This figures an example of 3 different patients, one without any delay in RAI, another who had a delay due to a CT scan, and the third who had a delay due to RAI from Lipiidol. You can see there's a stark difference in the urine iodine levels at similar time points, with the Lipiidol patient having 170 times greater than that in the CT scan. And even at treatment, we see that the urine iodine levels in our Lipiidol patient is 7 times that of what it was for the CT scan. Now we see that in the ATA response to therapy, 2 patients out of the 3 who required Lipiidol had concern for biochemical recurrence. One was at the 1-year mark, and the other one ended up being at the 6-year mark. So we conclude that Lipiidol for high-volume chyle leak is associated with a significant delay in RAI due to a prolonged iodine retention. But the true impact of this delay and iodine retention on the RAI efficacy may not be elicited for a few years given this disease process. And due to the rare nature of this complication, we believe that future multi-institutional studies are needed in order to truly understand the impact of Lipiidol on RAI efficacy and recurrence. We must also continue to discuss with our RAI colleagues different treatment options and imaging modalities for such a rare complication. So happy to take any questions.
Thanks for your presentation and drawing attention to this thankfully rare problem. Do you have any alternative strategies, a different agent? Is there something else you can do to approach this problem to avoid this issue? Or do we just have to deal with it?
Yeah. And the kind of why this came about was because, these are patients with high volume chyle leaks that are refractory to diet changes and TPN, and When we first discussed with IR, the question was, we know there's a delay due to a CT scan. What is it that you're using based on just our prior knowledge? And they let us know that it was this drug, but this drug is lipid-based instead of water-based like regular contrast, which then leads to this prolonged retention. However, unfortunately, that is the only option they so far use. And it's a very common drug that they use for all lymphangiography because it's just diagnostic, like a diagnostic option as well.
Thanks, yes.
So this is a really important study, I think, because this is obviously a very complicated problem. It's frustrating for everybody, but then it can become even more frustrating if the interventional radiologist is not aware of how it would conflict with their patient's future care. So certainly just bringing awareness to this is extremely important, so I thank you for that.
Yeah, thank you.
Thank you very much.
Yeah, thank you.
Next, we have Dr. Peter Abraham presenting National Assessment of Chief Resident Thyroid and Parathyroid Entrustable Professional Activity Data.
Thanks, Dr. Quill. And thank you all for the opportunity to present this work. So studies have shown that a majority of graduating general surgery chief residents are not comfortable performing straightforward thyroid and parathyroid operations. Entrustable professional activities, or EPAs, were implemented in July 2023 with the goal of shifting our profession towards a competency-based medical training paradigm. Therefore, the aim of this study was to evaluate general surgery chief resident competence with thyroid and parathyroid operations compared to other operations. To do this, we used the national EPA data set from the American Board of Surgery for PGY-5 residents from July 2023 to June 2024, which was the first year of EPA implementation. We evaluated thyroid and parathyroid EPA entrustment levels based on case complexity, phase category, and month of completion, and then compared these thyroid and parathyroid EPAs to other general surgery EPAs. For our results, we found that 3%, or 426 of 12,611 general surgery EPAs were for thyroid and parathyroid diseases. There were 128 chief residents that completed at least one thyroid or parathyroid EPA during that academic year, with 45% of those residents achieving practice readiness for at least one of those assessments. We observed a positive case volume relationship in which 49% of residents that logged at least 5 thyroid or parathyroid operations achieved practice readiness for at least one of those assessments, compared to a lower rate of 32% for residents that logged less than 5 EPAs for thyroid and parathyroid disease. We observed no difference in entrustment level based on case complexity. So for this table, this is specifically looking at intraoperative assessments. So we excluded pre-op and post-op assessments. So I want to draw your attention to that first row. So this is thyroid and parathyroid EPAs, and we're looking at the overall practice ready percentage. So you see that 40% of the chief residents had an assessment, 40% of the assessments by chief residents were deemed practice ready for that year. And then on the right column, this is a temporal analysis. So we used May 2024 as a proxy for the end of the year when they were close to graduation. And we found that 58% of the assessments for chief residents were deemed practice ready for thyroid and parathyroid operations. As you can see with the rest of the table, these results were significantly lower than what we found for other comparable general surgery EPAs for chief residents in that year. So in conclusion, we found that chief residents achieved practice ready status for less than half of their thyroid and parathyroid EPAs, which was considerably lower than other general surgery EPAs. This discordance raises really interesting questions about the inclusion of thyroid and parathyroid operations in core general surgery requirements. We believe that further longitudinal studies across multiple years of EPA implementation are needed to corroborate these findings. Thank you all again for your attention. I welcome any questions.
Dr. Sipperstein.
Hi, Alan Sipperstein, Cleveland. Very interesting study, and it's great that we are assessing the ability of our graduating residents. Did you compare these to other procedures that generally are done in high volume after fellowship training? number of your procedures are ones that general surgeons would do right in practice. So do you compare it to a carotid endarterectomy or distal pancreatectomy? Thank you.
Yes, great question. So, we are limited by the EPAs themselves, so we can only, judge based on the EPAs that we have. So it would be interesting to look at, some of the EPAs for more nuanced things, but, we don't have one for specifically a, distal pancreatectomy or, carotid endarterectomy.
Thank you very much for your presentation. I agree that, not as many people are practice ready as you would ideally like, but as I looked at that data, the numbers were almost identical to that for inguinal hernia. And I think everyone in the room should argue that hopefully our general surgery residents are competent in inguinal hernia when they finish. And so I would say the opposite maybe could be I just worry about the interpretation of this data because maybe it's just the way people are filling it out that people are not maybe granting the independence that they should be for people. Because if we're not training if only 59% of our graduating chief residents are competent to do an inguinal hernia, then I think it just implies that maybe our educational system isn't doing what it should for our graduating residents.
Thanks, Dr. Sibyl. I completely agree. This came up in the poster session when I presented this work, and I agree that both things are concerning, and I think it's a both and in that we should be ensuring we have proficiency in all operations that our trainees are going to be performing as attending. So I agree. I think inguinal hernia is also concerning in addition to the thyroid low levels.
Saray Paranga, Boston. Thanks for this great work. I think it's really important. I was wondering if you found any difference by male or female status of either the chief resident, I guess.
Yes, so the data set we were provided by the American Board of Surgery was de-identified, in which we could not specifically look at that. It would be interesting to look at, but we didn't get into that granular level of detail for this. So it was just a large data set with just the de-identified trainees.
Yeah, because I have seen other work presented showing that there is a difference, especially when there's self-assessment as part of the equation. So I do think we're going to at some point have to look at this, but I'm going to leave that to smarter people like you and Vanessa and everyone.
Yeah, that's a great point. Thank you.
We'll take one last question.
As a general surgery program director, I really caught on the thing of maybe we shouldn't make this one of our case requirements. And then as my AES endocrine surgeon, I'm like, no. I think there's a lot to be gained. Most of the residents that we're training to do this may not be doing this. A lot of them won't. They're going and doing fellowships and all kinds of things that aren't anywhere near the thyroid. But having that anatomy, that understanding of the anatomy and the neck and whatnot, I think is fine. And same thing with inguinal hernias or whatever. Nobody feels, the ones that do feel uber comfortable when they graduate are the ones I worry about a little bit because they should be a little bit uncomfortable when they go out. And so I think that expecting when we have fellowships and things for people to be uber comfortable and practice ready to do a distal panc on their own when they don't do surg-onc or to be able to do a beautiful thyroid if you haven't done a lot of beautiful thyroid IE fellowship is going to take some mentorship from senior partners if they go into private practice or whatnot. So it worries me a little bit or hesitate a little bit with the comment of, well, maybe this shouldn't be part of their thing. If you want to take something away, open thoracotomy, I'd really appreciate you take that out of the general surgery requirements.
Sorry, can you just, I'm not sure if we missed it, just introduce yourself and your institution.
Courtney Lee, Lexington, Kentucky.
Thank you so much, Dr. Lee. And Dr. Abraham, you can address that question.
Yeah, thank you, Dr. Lee. And I just want to be clear, I'm not suggesting that we take out thyroid and parathyroid by any means. I actually personally, to share my bias, I believe we should continue to have thyroid and parathyroid as a core general surgery requirement. But I do think the interesting question is, as we're shifting towards a competency-based medical system, we need to figure out what that's going to look like. We still have 5 liver, 5 pancreas, open thoracotomy was suggested. I think there are still a lot of cases that it's important for general surgery residents to be exposed to, but we have to think about the difference between exposure and proficiency. And so that's why I think things like focused practice designations, other things that are, our institution and our community is doing is important because, as we all know, high volume, leads to better outcomes for the patient. So I do think that we want our surgeons to be proficient, high volume surgeons that are going to take the best care of patients. And so I think that's the distinction that we need to figure out as we move forward. So,
thank you so much.
Yeah, thanks.
Our final presentation is from Dr. Dominique Patroc, population-level trends in survival for anaplastic thyroid carcinoma in the era of immunotherapy, and NCDB analysis from the Swedish Medical Center.
Hello, thank you for the opportunity to present my project. I'd like to start by thanking my mentors, Dr. Sneezik and Dr. Lassus, and my residency program at Swedish for their support. I do not have any financial disclosures. Anaplastic thyroid carcinoma, or ATC, is a rare but devastating disease. Although it accounts for only about 1% to 2% of thyroid malignancies, or roughly 500 cases annually in the United States, it is responsible for up to half of thyroid cancer-related deaths. Historically, outcomes have been poor, with median overall survival of only 4 to 6 months. In the recent years, however, we've seen important therapeutic advances, including targeted therapy for BRAF mutations and the emergence of immune checkpoint inhibitors. Single institution studies have suggested meaningful survival improvements, particularly when therapy is combined with surgery. However, it remains unclear whether these benefits translate to the broader population. So to address this, we utilize the NCDB to evaluate survival trends in ATC in the modern immunotherapy era. We identified 4,397 adults diagnosed with ATC and no prior malignancies between 2004 and 2021. Patients with missing survival or immunotherapy data were excluded. We stratified patients into 3 treatment eras: pre-immunotherapy from 2004 to 2015, early adoption from 2016 to 2018, and the contemporary era from 2019 to 2021. Survival was analyzed using Kaplan-Meier methods and multivariate Cox proportional hazards modeling, adjusting for demographic, clinical, and treatment factors. Because the majority of immunotherapy use occurred after 2017, we then performed focused survival analysis within this time period. Within our total cohort, 182 patients received immunotherapy. These patients tended to be younger, with a mean age of about 66 compared to 70, and then they were more likely to have private insurance and were more frequently treated at academic centers. There were no differences in comorbidity burden. Importantly, we observed improved survival over time. Median survival improved from 3.78 months in the pre-immunotherapy era to 4.0 months in the early adoption stage, and then to 5.39 months in the contemporary era, with a highly significant log-rank p-value. When we examined immunotherapy specifically, the difference was even more pronounced. We conducted analysis on patients from 2017 to 2021. In this cohort, 120 patients received immunotherapy and then 682 did not. Patients who received immunotherapy had a median survival of 12.9 months compared to 3.9 months for those who did not. This survival benefit persisted on time-dependent multivariable analysis with a hazard ratio of 0.58. We were curious regarding the role of surgery in these patients. We found that in this cohort, 80 patients received immunotherapy without surgery, and then 102 underwent immunotherapy and surgery. Those who underwent both surgery and immunotherapy were more likely to have improved survival at a median of 21 months compared to those who underwent immunotherapy without surgery, which was a median of 7 months. Whether these differences are related to the treatments versus tumor biology remains to be clarified. In conclusion, patients with ATC who received immunotherapy demonstrated significantly improved survival at the population level. While prognosis remains poor and our study is limited to the inherent constraints of NCDB data, these findings suggest meaningful progress in the modern era. They also underscore the importance of continued expansion of precision-guided and multimodal care for this aggressive disease. And thank you for your time, and I look forward to your questions.
Thank you. Dr. Perengi.
Hi, Surya Parangi, Boston. Thank you for presenting this work to this group. I think it's really important for everyone to see this, well, really massive C wave change in survival in this disease. I didn't catch it, so were these all BRAF mutated tumors or not?
These are just all anaplastic thyroid cancers. It kind of came up during the judging the judging session. So I was thinking maybe in the future I can do some more analysis to see the difference of patients who receive targeted therapy and immunotherapy and try to stratify and see if we can detect any nuances in survival based on those treatments.
And this was not immunotherapy alone, right? I think, if I had to guess.
Correct.
Yeah.
So these patients receive like chemotherapy, radiation, surgery.
Okay, yeah. So if I think you should, because I think what you will show in this large data set is that, you know, the people who are BRAF mutated are going to show even improved survival. So, you know, the message to everyone, I think, should be, if you have an ATC patient, the first thing you should do is check their BRAF status, and then, like you say, be as aggressive as possible and include immune therapy. Great job. I think it's really important work.
Thank you.
Thanks.
Thank you.
All right, that concludes this session. Thank you again to all of our presenters, and thank you to my co-moderator.